So it's interesting to see that we started with the diseases at the beginning of the day where immunotherapy really works, and now we're migrating down to those diseases where maybe it works a little bit less well. But what I hope to show you in the next 20 minutes or so is that immuno-oncology drugs have efficacy in patients with head and neck cancer. So those are my conflicts of interest. I would stress the fact that all of those funding, all of the funding from those goes directly into the institute for which I work and is spent on paying for research rather than paying for personal gain. In terms of the treatment landscape in head and neck cancer, in patients with relapsed metastatic disease, immuno-oncology drugs are now established as standards of care, with both nivolumab and pembrolizumab being approved, in fact, globally now for patients with this disease. Pembrolizumab not so here in Europe as yet, but there is a pending CHMP application, and we await the result of that. The data in support of the use of second-line PD-1 inhibition comes initially from the phase 3 Checkmate 141 study. Now, I show you the data from the original publication from Bob Ferris in 2016, and I'll show you some updated data that give us greater degree of confidence in these data, albeit we had enough confidence in these to get an FDA approval. So you can see that this is in a group of patients with relapsed metastatic head and neck cancer of squamous histology, patients who had progressed within 6 months of their last dose of platinum chemotherapy, irrespective of the number of lines of treatment that they had received. And the only stratification factor for this study was prior cetuximab. So PD-L1 was not used as a stratification in this study. Patients were randomized 2-to-1 between standard dose nivolumab. Indeed, nowadays we would use perhaps the 240 milligram dose, but this was 3 mg per kg, versus investigator choice of relatively ineffective single-agent chemotherapy. And you can see there for yourself methotrexate, docetaxel, or cetuximab. I just draw your attention to the fact here that the dosing of docetaxel was weekly rather than 3 weekly, and the primary endpoint, as you would expect for a registration study, was overall survival. Now, these were the data that were published in the New England Journal of Medicine looking at overall survival. And you can see here that the 1-year overall survival in a second-line population, where the quoted median overall survival was about 5 months previously, you can see that the median overall survival is significantly better for nivolumab compared to investigator choice that performed exactly as we would expect it to, with a hazard ratio of 0.70. And the 1-year overall survival rate was more than doubled for patients receiving nivolumab versus investigator choice chemotherapy. I show you now data that have been published recently by Bob Ferris and colleagues, including ourselves, as showing the 2-year data now. And you can see that although the 12-month number has narrowed slightly, there is a significant robustness now to the tail on the curve, demonstrating even at 24 months, 1 in 6 patients alive at 2 years. And again, you can see there the median overall survivals have in fact improved a little bit in favor of nivolumab, and the hazard ratio has tightened in terms of its confidence intervals and has become 0.68. The discussion about PD-L1 has been brought up, and PD-L1 expression has been brought up more than once already in this symposium, as you might expect. And you can see here the data from the original publication in the New England, demonstrating that for those patients with PD-L1 expression greater than 1% versus those with expression less than 1%, there appeared to be a difference in outcome. And you can see for yourself there that the hazard ratios are much more convincing in favor of the patients expressing PD-L1 at greater than or equal to 1% than those with a lower level of expression. Nonetheless, those data were presented to the FDA and also to NICE within the United Kingdom, and some of you may know that's a fairly tough hurdle to clear. NICE approved the drug, actually, for patients irrespective of PD-L1. And it's interesting, actually, that the 2-year data now show a significantly better outcome for patients with PD-L1 expression less than 1%. Indeed, I think making good on the decision of NICE to approve this irrespective of PD-L1 status. And so you can see that the hazard ratio is now 0.73 as opposed to 0.89 at that earlier analysis for the patients with PD-L1 low tumors. Again, reinforcing the fact that PD-L1 expression in and of itself is a relatively poor biomarker in this disease. What about for patients with oropharyngeal cancer, P16 positivity versus P16 negativity? And you can see here that there is a hint that the patients who have P16 positive HPV-driven tumors, potentially with viral etiology and therefore potentially an antigen that the immune system could go after, seem to do better than those with P16 negative disease. I ask you to remember these data because I will show you data for pembrolizumab that are at variance with these results. And you can see for yourself what the hazard ratios are, 0.56 and 0.73 respectively. Now, since last year, the data from the Keynote-040 study have been presented, and this was a study with very similar design in second-line setting of pembrolizumab versus investigator choice, initially presented by Ezra Cohen at ESMO. And I'm going to show you these data really as an illustration of potentially how not to design a statistical analysis plan when conducting a phase 3 study. There is a lesson to all involved here. And I was involved in this because I sat on the steering committee, so I share the blame. In terms of this study, you can see that it was a randomized phase 3 study, similar group of patients to the patients in Checkmate 141. Look at the difference in stratification factors there. Learning from some of the examples of other studies that have been published in the meantime, the stratification included ECOG performance status, P16 status, and PD-L1 tumor proportion score of greater than or equal to 50%. And you can see that the randomization here is between single-agent pembrolizumab or those same 3 drugs administered as single agents. But note here, please, that docetaxel was given on a 3-weekly schedule as opposed to the weekly schedule given in the Checkmate 141 study. These are the data presented by Ezra Cohen at ESMO last year, and these are the overall survival data from the intention to treat population. And you can see there that the p-value is 0.0204. Of course, that should, you would imagine, be a signal for champagne corks popping and celebration amongst the investigators. But when designing this clinical study, and I told you before that this is one of the lessons that I have learned, when designing this clinical study, in the race to analyze the data as early as possible, some of the alpha, some of the statistical power of the study was spent on an early interim analysis, which meant that this one-sided p-value had to be less than 0.0175 in order for it to be formally statistically significant. So this study, in spite of the shape of those curves, in spite of the difference in median overall survival, in spite of the difference in 1-year survival, is formally a negative phase 3 clinical trial by definition. But of course, it's difficult actually to understand that in terms of it being a negative phase 3 study. And I'm going to show you how we have reanalyzed these data and how we've tried to reinterpret these findings. These data were presented, and obviously there was significant concern about the fact that pembrolizumab was now being seen as an ineffective treatment, given the fact that it was FDA approved. And interestingly, the FDA did not withdraw its approval for this drug in the United States, even though these data are in the public domain. When we look at Ezra's presentation, you can see here that overall survival well broken down by these 2 factors that were part of the initial statistical plan, by the combined pathological score greater than or equal to 1 and the PD-L1 tumor proportion score of greater than or equal to 50%, you can see that there is a marked difference in terms of overall survival. Notice I do not say statistically significant, because of course in a formally negative study with the primary endpoint not being met, you cannot conduct these analyses with formal statistical power. So these are nominal p-values that you can see. So that p-value there formally cannot be considered to be a statistically significant result. When we look at the subsequent analysis of these, and these data were presented by Denise Soulière at AACR earlier this year, what happened was that in the original design, a number of patients were not included in the final analysis of the survival, and that was because the analysis was triggered after a number of events had been reached. Subsequently, the company and the investigators were able to track down what had happened to the missing patients and provide full acquisition of data with exactly the same data cut point. So there was no prolongation of the data cut point. So this is actually the same statistical analysis, just done properly with all of the data. And these are the analysis populations. You can see here that we formerly had planned to analyze based upon CPS greater than or equal to 1 and TPS greater than or equal to 50%. And you can see there for yourself the key endpoints, primary endpoint being overall survival. And you can see there that the efficacy boundary was set, as we've discussed, at 0.0175. So these are the interesting observations in the study. The first observation is that in the standard of care arm, and those of you who've randomized patients into studies in which some patients do not receive an immune checkpoint inhibitor will recognize the fact that a number of patients will take themselves off study and go elsewhere seeking an immune checkpoint inhibitor. 14 patients did not receive standard of care treatment. Of the patients who did receive treatment, you can see that 23 patients had either continued treatment or had actually completed 2 years of therapy, whereas in the standard of care arm, that was for the immune checkpoint arm, for the chemotherapy arm, only 2 patients were still ongoing and none of the patients completed 2 years of therapy. Here are the data for the updated overall survival with full acquisition of the survival analyses. And you can see here now that the p-value is actually less than 0.0175. But again, when presenting these data for publication, and they are currently under revision at a famous journal, this study remains formally a negative phase 3 clinical trial because it did not meet the protocol-specified primary endpoint, which is the correct way to analyze the study. But nonetheless now, we are at least able to talk about this being clinically beneficial. And you can see that there is about a 1.5-month difference in median overall survival and a difference in 12-month survival rate. I don't show you the data, but the number of patients in the standard of care arm who subsequently crossed over and received immunotherapy either as standard of care or in a second protocol was 12% in the standard of care arm and only 3% in the pembrolizumab arm. Again, potentially showing some effects potentially of crossover in these studies. And again, if we look at the same analyses based around CPS and TPS greater than 50%. Again, you can see that the hazard ratios are strongly in favor of pembrolizumab, but again, I hesitate to call them formally statistically significant because, of course, this is formally a phase 3 study that was negative. But you can see for yourself what those data show. When we look at progression-free survival, and no study hitherto had shown an improvement in progression-free survival in this population of patients, you can see here that for patients with PD-L1 status TPS greater than or equal to 50%, there was actually an improvement in median progression-free survival. And again, this is the first time this has been observed, albeit in a relatively small population of patients. And when we look at the subgroup analyses, and again, when you have a formally negative phase 3 study, always go to the subgroups. You can see here there are some interesting observations. The elderly population, albeit in relatively small numbers, appear to be those who are benefiting to the greatest extent in this study. That is out of line with previous studies in head and neck cancer in palliative situations. And interestingly, the group of patients who did less well were those who were in North America, which is exactly the opposite from the Checkmate 141 experience, but almost certainly reflects the fact that a number of those patients may have received immune checkpoint inhibitors in second-line setting or in third-line setting, rather. And when we look at prior lines of therapy, you can see that patients who were treated or relatively undertreated previously had not received a large number of regimens with those who were most likely to derive benefit. And patients receiving docetaxel did less well or didn't show the same benefit with pembrolizumab. In terms of biomarkers, we remain really no further forward than we have been for the last year. These analyses, again presented in ASCO last year, demonstrate that the best that we have at the moment reflects a fusion of data from the microenvironment within the tumor and the gene expression profile, so the mutational load and the immune signature. And you can see here that for patients who have a high mutational load and have a gene expression profile that looks like an inflammatory hot tumor, the response rate is as high as 40% in patients with head and neck cancer. And this at the moment is the best that we have to go on. Having shown you now 2 positive phase 3 clinical trials, or at least 1 positive and 1 clinically interesting phase 3 clinical trial in second-line setting, I just want to draw your attention to the fact that we have had negative results in the last 12 months as well. So the CONDOR randomized phase 2 study looked at the addition of an anti-CTLA-4 monoclonal antibody on top of an anti-PD-L1 drug. So this study, which is durva plus tremi versus durva versus tremi as single agent, notice no control arm in this phase 3 study, set out to see whether or not there was an additional benefit from combining these drugs. Notice that the doses of the drugs used were relatively low compared to the melanoma experience in an attempt to mitigate toxicity in the group of patients with head and neck cancer, not least of all patients with lung disease. And disappointingly, these are the data for progression-free survival, demonstrating that tremi is almost inactive, as far as we can tell, in this group of patients as a single agent, and its addition to durvalumab adds little. In terms of overall survival, there is little evidence that the combination of durva-tremi does anything over and above durva as a single agent. And these data in a population of patients who were PD-L1 low, as defined by less than 25% PD-L1 positivity in the tumor, I think are a wake-up call, as I'm going to show you, to the phase 3 clinical trials involving PD-1, PD-L1 plus CTLA-4 combinations. But actually no evidence of activity here in this group of patients. What about in the first-line setting? There are 3 phase 3 clinical trials that have either completed recruitment or are on the threshold of completing recruitment, and I can show you that these involve a number of different approaches. So the Checkmate 651 is a straight comparison between standard of care chemotherapy, platinum 5-FU and cetuximab, versus nivolumab and ipilimumab, CTLA-4 plus PD-1. Keynote 048 is a more complex design, the same extreme standard of care chemotherapy versus either single-agent pembrolizumab or pembro plus platinum 5-FU, so chemo-IO combination a la lung cancer. And then the third trial, the Kestrel study, is again a combination of the extreme regimen with durva versus durva plus tremi. Now, this is the same durva-tremi that I've shown you performed so badly in the CONDOR study, causing some anxiety in the investigators involved in the Kestrel study. We don't yet have formal data on any of these studies that have been presented in the public domain, but there was a press release about 3 or 4 weeks ago reporting, to everyone's surprise, I have to admit, that single-agent pembrolizumab had outperformed combination chemotherapy in first-line treatment of patients with head and neck cancer for those with a CPS greater than 20. So a biomarker-selected, a predetermined biomarker-selected population where single-agent PD-1 inhibition has beaten chemotherapy. And that is a very encouraging result. The full analysis of the data will come later this year or early next year, where we await the combination of the chemo-pembro versus chemo combination. I also draw your attention to IDO1 as a target and the huge enthusiasm that existed this time last year around epacadostat. Everyone wanted to be doing trials with epacadostat. In head and neck cancer, we were running 2 clinical trials with epacadostat based around data using epacadostat in combination either with pembrolizumab or durvalumab. You can see the waterfall plots, you can see the spider plots, illustrating perhaps that this drug looked like it was going to really improve outcomes for patients with this disease, because head and neck cancer, like melanoma, has high levels of IDO1 expression. So, of course, when the negative study for melanoma was reported, and you've seen those data from Reinhard Duma earlier today, we expected, but nonetheless were disappointed to hear that both Bristol Myers Squibb and Merck Sharp Dohme were discontinuing their phase 3 trials immediately, even though we had patients on study who continue on study, but albeit in relatively small numbers. I'm a radiation oncologist, and of course I have an ongoing interest in combining immunotherapies with radiation. And the basis of this, again, which has been rehearsed in previous symposia, indeed I remember these data being presented last year, there is a good deal of interest around radiation-induced immunogenic cell death. Radiation is capable of releasing a number of the key hallmarks of immunogenic cell death, including display of calreticulin on the extracellular membrane, release of ATP and HMGB1, activation of dendritic cells, cross-priming by dendritic cells in lymph nodes to activate and expand T-cell populations, which in theory should be able to mediate anti-tumor effects. And simultaneously, radiation may suppress suppressors of immunotherapy, including some of the MDSC, Treg, and tissue-associated macrophage, particularly the M2 phenotype. So there is significant interest in this, and there are a number of ongoing studies, and I show you the design of two of the studies which are nearing completion. The Javelin 100 study is now about 3/4 recruited. The Keynote 412 has passed the halfway mark, and these studies involve effectively a lead-in period with either a PD-L1 inhibitor in the form of avelumab or a PD-1 inhibitor with pembrolizumab, followed by standard of care chemoradiation, and then an adjuvant phase of treatment, again in line with the data from the Pacific lung cancer study. And just as a few final closing remarks, one of the areas that I see as potentially a big opportunity for us in head and neck cancer and other diseases where we treat tumors with curative intent with radiation and or chemotherapy is the addition of drugs that modulate DNA damage responses. So this time last year, there were 2 papers back-to-back in Nature looking at the role of micronuclei in mediating anti-tumor immune responses. And so these data taken from that study demonstrate that in a sting knockout mouse, the beneficial effect of adding an anti-CTLA-4 antibody to radiation disappears when the animal does not have the sting pathway, so the stimulator of interferon gene pathway activated. And indeed, the immune infiltrate that you see that improves with radiation and CTLA-4 disappears when there is no sting signaling. And the data from this paper demonstrated, in fact, that the generation of micronuclei, so bits of chromosomes that fall off and are maintained in a cytoplasmic setting with a non-intact nuclear membrane, are able to signal through C-gas and into sting in order to act as platforms to generate interferon-type responses, potentially leading to both local inflammation and paracrine signaling. And radiation in generating these may well be activating immune responses. We and others have interest in using drugs that modulate the formation of micronuclei, and both ATR inhibitors, which are in the clinic, and CHEK1 inhibitors, which are also in the clinic, have the ability to enhance the ability to form micronuclei, and these are data from Magnus Dillon in my laboratory in London. And data that are currently, again, under review for publication demonstrate that when you combine radiation with an ATR inhibitor, you increase the inflammatory infiltrate in tumors, and indeed we have data in patients that demonstrate similar effects. So in conclusion, I've shown you that nivolumab and pembrolizumab are established as second-line treatments for patients with relapsed metastatic head and neck cancer. There is significant clinical activity in the first-line setting. Indeed, we've seen a press release, but none of the data on a first-line study demonstrating that pembrolizumab as a single agent has defeated extreme regimen in a biomarker-selected population with CPS greater than 20. A number of studies are ongoing in which PD-1, PD-L1 drugs are combined with chemoradiation, and the results of these studies are awaited with interest. And I've suggested that maybe the generation of micronuclei might be one way that we can enhance the immunogenicity of radiation, perhaps using DNA repair inhibitors such as ATR inhibitors or CHEK1 inhibitors, amongst other drugs, PARP inhibitors, for instance. So with that, I close showing you a photo of some of my team in London, and particularly I would like to point out Martin McLaughlin and Magnus Dillon, who conducted the studies with the CHEK1 and the ATR inhibitors. Many thanks.
Thank you very much. We have questions?
You know, I was wondering how you explain or reconcile that in the head and neck trials with chemo-immuno combinations, but or also in the lung trials, in the low PD-L1 expression, progression-free survival is no difference, but the survival is different.
Yeah. You know, like you, I wish I knew the answer to that question. Something happens, doesn't it? Something happens to the tumor, something happens to the patient that means that irrespective of progression, that patient with either subsequent intervention or simply due to a low-level activity of their anti-tumor immune response, which isn't sufficient to prevent formal progression on scanning, something happens that improves the overall survival of the patients. There are data, and again, I think these have been presented in melanoma, in lung cancer, and in other tumors, and these data now emerge in head and neck cancer, that patients who have failed immunotherapy, who then go on and receive chemotherapy, and the data are clear now, most prominently for taxane-based chemotherapy, and indeed for cetuximab in some studies, those patients have a greater chance of response, and that response may be more durable. So there is this hand-waving argument going on, and I'm guilty of it, the same as others, that there is something happening in the tumor that is conditioning those tumors to subsequent response to chemotherapy. I wish I knew what it was, because then we would make it happen more regularly.
Thank you.
So in a checkmate 141, we had the results showing that PD-L1 negative benefited long-term, 2 years,
Yes.
2-year analysis, and in the keynote trial, the expressions seem to be very relevant. So what are your thoughts on the those very different results?
Thank you for pointing out exactly. There is potentially an inherent contradiction in those studies, and I think we await the longer-term data from the Keynote 040 study. But I think the data are not incompatible with one another. So I think that the group that is most likely to achieve the greatest degree of benefit are going to be the patients with the very highest levels of expression. So the PD-L1 greater than or equal to 50% group may well be that group of patients. I hope in the first-line setting, like in lung cancer, we may be faced with the choice, do we give them just single-agent pembro rather than having to give them pembro chemo? We don't know what the full results of Keynote 048 are yet, but maybe that's the choice that we will face. But I think that group of patients may get the greatest benefit from PD-1 inhibition. Nonetheless, I think even for patients who have relatively low levels of expression, 1%, even less than 1%, they may well still derive benefit from those treatments. But I suspect that in the first-line context, and we wait to see what the data are, maybe that's the group where we're going to be thinking, like in lung cancer, should we be combining chemotherapy with immune checkpoint inhibition? We don't know, but I think the findings are not incompatible.
Maybe if I may, just another question. The fact that a Taxotere was given in a weekly regimen in Checkmate 141 and a 3-weekly in a Keynote, do you think it shows the difference in the population? Is this a bias? I mean, you wouldn't give to some patients, you wouldn't give Taxotere 75, right? Maybe, but that's what the protocol said. As you know, you put patients into these studies, I think. You had to say at the outset, if the patient was randomized to standard of care chemotherapy, what would you give them? And so the investigator had the decision at the time of randomization, if you had a really fit patient sitting in front of you in Keynote 040, you could say, I'll give them docetaxel, and I'll be quite happy that it's the higher dose 3-weekly regimen. Whereas if you had a less fit patient, you could say, well, I'm going to give them methotrexate. So you're absolutely right, there is a potential bias there. And the same process operated in Checkmate 141. So there may well have been an introduction of investigator-led bias there. I think so. But in fact, in both of the studies, the patients who did receive docetaxel, as you know, did better than the patients who received the other drugs, because it was the fitter population with more active drugs.
Well, thank you a lot for your talk. Thimios Mitsiadis from the Institute of Oral Biology. I'd like to ask you if there is any specificity about the immunotherapy that is chosen for the oral cancers, oral-related cancers, and other cancers in the body. And if yes, why?
So not yet. We have no specific selection based around oral, if your question is around oral cavity cancers versus other tumors in the head and neck, we don't. You may be aware that within the United Kingdom, the approval for cetuximab-based therapy is exclusively for patients with oral cavity cancers, a decision by NICE that I find utterly bizarre and is not supported by the data, but that's nice. They do what they want, and it carries weight. But I don't know of any reason why we would select a PD-1 or a PD-L1 drug or an anti-CTLA-4 drug for a tumor in the mouth versus the larynx versus the hypopharynx. The subgroups are not big enough for us to know those things yet. I think when we've got a number of phase 3 studies and we can start doing meta-analyses, maybe some of these hypotheses will begin to fall out and we can formally test them in trials. But as yet, no.
Before we let you go, most radiation oncologists at I/O meetings, when they come to the end, they start dreaming a little bit about abscopal effects. You didn't do that. Is that a fantasy? Any thoughts on whether this is still real?
So I am a radiation oncologist, and I would love the abscopal effect to be real. There is nothing I would like more than the notion that you can irradiate a tumor over here and somehow you can train your immune system to kill the rest of the disease. I sometimes make the joke that I can count the number of times I've really seen an abscopal effect in patients receiving just radiation alone on the fingers of one hand. And in truth, I can actually count it on the finger of one finger. I've only ever seen it once, and I've been working as a radiation oncologist now for over 25 years. I think it does occur. I think it's vanishingly rare. I think the notion that we can start using immunotherapy drugs simply to kickstart abscopal responses all over the body in most patients at the moment is wishful thinking. I don't want to go as far as fantasy. It's wishful thinking.
Thank you. It was helpful anyway. Okay.